Any afterthoughts? I hope you remember we covered the topic of addressing complaints, managing and resolving complaints. That was the topic. Okay, if there are no questions about the last session, today we are going to take it further. And as you remember, we had discussed about the communication scores of everyone. And we did try to understand what are the different communication styles. Taking it forward, we are going to do another role play today. And this role play will be where the patient's family is acting little uncooperative. The situation is that the patient is in critical condition, but the family is insisting on moving the patient to another hospital. So I'm sure this is again a very common situation we all face in our workplace. And it's important to understand what is the right way of handling this situation. And without being aggressive, without being unhappy, how do you really assert and help the patient understand or the family understand? So that's the situation. I would want 3 volunteers, maybe somebody who would act as a doctor on duty, and then 2 patients attendants who would go to the doctor in the ICU requesting that we want to take our patient, and then the doctor has to try to help them understand. But like the doctor has to try to strike a conversation with the patient's family member. We don't require a patient. So I'll share the case also. I'll share a case situation. And after this situation, I'll show 4 small videos, like a minute long video, to understand different ways of handling such situations. But before that, I think we'll have a role play, and then we'll discuss different communication style. And the next topic that we are going to cover will be handling aggressive patient party. I think that's another situation we often experience when we are dealing with the aggressive, patients or their family members, and how we lose our control. And sometimes things really escalate so fast that we really lose control of the situation, and it turns into violence and kind of sometimes, sadly, mob attack on us. But that's part 2 of the session. Followed by that, we will have presentation by 2 of our presenters. Although 3 people had planned, but I think we may not have time to accommodate.
And you call this alone,
Dr. Matani, I think your audio is on. Can you? Yeah.
क्या हो गया?
Okay. So I'll just share the situation first, and then I would ask you to volunteer. Give me a second to share the situation. Okay, so this is the case. This is patient Sunita, 58 years old, brought to your hospital emergency with the following details. It's a case of multi-organ failure, and condition is really, really bad. And the family wants to move the patient to another hospital. They want to go Lama. So Rashmi ji may want to understand what is Lama. So Rashmi ji, Lama is left against medical advice, where the patient and the family decides to get discharged against the medical advice. And we have to take signatures from the patient's family that they are going on their own and they are responsible for the consequences. So if you have seen the case, I would like one of you to volunteer who would be willing to play the role of the doctor on duty, resident on duty, and then 2 patients attendants who are just not ready to budge. Any volunteers? Okay. Dr. Janvi has raised her hand. So Dr. Janvi, I'm so sorry, Dr. Vaibhavi, I'm so sorry. So Dr. Vaibhavi, you would like to play the role of the doctor on duty, resident on duty? Okay, okay. So I need 2 volunteers to act as patient's family member. somebody who can really, stick to the stand that I don't want to stay in your hospital. I'm very unhappy with the services and the conduct. Anybody? Dr. Kapoor, would you volunteer? Okay. Then one more person. Okay, Dr. Ravi Matani. Thank you. Thank you, both of you. So I think, again, we will switch off our videos. We'll let three of them be here and assume that Dr. Vaibhavi is in the ICU, and both of you enter the ICU, and let's see how Dr. Vaibhavi strikes conversation with you. If I pop in, that means I have to say something, or I want to put in some, ask a question or something. Otherwise, we'll keep our video on. And for everyone, please keep noting down things that Dr. Vaibhavi does good, that you think really help to manage the situation. And then you can also add on something that you think she could have done, or I mean, if you would have been in that position, you would have done it. So I'm also going to stop my video. Let's keep the discussion, say, for 2-3 minutes, 3 minutes total. Okay.
Okay.
Okay. Yeah. So there we go. Yeah. Go ahead, please. Yeah.
Hello.
Dr.
I
Matani,
can't hear.
your audio is muted. Please unmute your device.
Sorry. Is that okay now?
Yeah.
Yes.
Yeah. Okay. Yes, ma'am. We had brought our patient in the morning, and she was quite okay, although she was a little unwell. Her condition has deteriorated very drastically, and y'all are saying that the chances are very remote of improving, and we are quite unhappy with whatever has been done. So, if with the we will be taking her, we will be moving her to another hospital right away, because we don't think that over the next few hours we can see any change in whatever your treatment or what you are planning to do.
Mr. Matani, I guess the patient is your sister, am I right?
Yes.
Yes. I'm Dr. Vaibhavi. I've been the doctor for her the whole day today, and I have observed her for the whole day. And as you mentioned, you're right that her condition is quite critical. Uh, Her multi-organ failure has happened, and many of her organs are not working. At present, she is on the highest of support from the ventilator, for her breathing, for her blood pressure. All efforts are done to make sure that she does not bleed anymore. And also, if blood transfusion required, we have kept everything ready to go in. I just want to let you know that yes, you have an absolute right to take your patient to any hospital.
Hmm.
My concern is that she may not be able to bear the transport with all these ventilators, with all the
No,
medications
but
that
ma'am,
she's on.
sorry, but then what is I don't think she will last through the night, because at least from morning we have been seeing, okay, whatever, you all found out that she had a bleed and all, but, or we could have been told that, that her prognosis is very poor and her chances, and we are, as you can understand, we are quite anxious, and we
I
feel that
understand.
maybe, she might get some better treatment. We would not, have it on our head that we did not do the very best for her.
I think I understand what you're saying, and it is out of the concern and love for your patient that you want the best to happen.
Yes.
Let me assure you that the treatment here that we are giving is absolutely the best. In fact, if you have already spoken to any other hospital or any other doctors whom you want to, consult, I'm willing to speak to them and tell them the situation. And even if that doctor there says that they're willing to take the risk of, transporting her in this situation, I'm absolutely fine. But from my side, it is my responsibility to let you know that the transport in this situation is quite risky. In fact, she may not survive the stresses of transport, shifting her to a trolley, then to an ambulance, to the other hospital. She's quite in a delicate situation. I agree that you do want to have a second opinion, and absolutely open to talk to any doctors whom you have trust on. so that we all together can
No, but
decide what step we
they are
can do.
not in this hospital, ma'am. They will not be allowed to, touch the patient or do. We can see her sinking, you know.
I know. You can bring them here, all the doctors. I can discuss with
Are
them.
they
I'm
allowed?
absolute. Yes, they are allowed. They can come here
Oh, okay.
because it is better that they come here and see whether she's able to be
But ma'am,
shifted.
no doctor will be willing to come and see like this because they are okay to deal with your patient like in their own hospital, but no doctor will be ready to come
In
and
fact,
see.
there is the patient has a right to call the doctors from any hospital, and it is absolutely fine for the hospital system to accept second opinions. So, in fact, we are all open in our hospital to interact with them and let them know how the situation is.
बट मैम कोई डॉक्टर आने के लिए रेडी नहीं होगा ना, वो कह रहे हैं कि यहाँ ले आओ, अब हम आपको
अच्छा,
हाँ,
देखने के लिए नहीं जाएंगे। कौन सा डॉक्टर है जो आप जाएंगे किसी और हॉस्पिटल में देखने के लिए अगर कोई पेशेंट आपको रिक्वेस्ट करेगा तो?
आई अंडरस्टैंड। इनफैक्ट ये जो रिस्क है कि शी इज ऑन अ डबल एज सोड, अगर ये ट्रीटमेंट का कुछ मिनटों के लिए, घंटों के लिए भी इंटरप्ट हो जाएगी, तो उनके लाइफ के लिए बहुत बड़ा खतरा है। ये रिस्क जानते हुए भी अगर आप उनको ले जाना चाहे तो मैं रोक नहीं सकती हूँ।
हम कोई
एब्सोल्युटली
कागज
यू हैव
वागज
द
साइन
राइट।
नहीं करेंगे, हमें सिस्टर कह रही थी आपको कागज साइन करने पड़ेंगे, हम कोई कागज वागज साइन नहीं करेंगे।
हाँ।
इनफैक्ट अगर कागज साइन नहीं होंगे तो हम आपको ऑफिशियली परमिशन नहीं दे सकते उनको ले जाने के लिए।
बट
और
फिर कुछ
आपको ले
होगा तो
जाने के
आपकी
लिए
जिम्मेदारी है. इट्स योर रिस्पॉन्सिबिलिटी देन.
ये रिस्पॉन्सिबिलिटी अभी हमारी है बिकॉज यहाँ पे एडमिटेड है, लेकिन अगर आप यहाँ से ले गए तो हमारी रिस्पॉन्सिबिलिटी नहीं हो सकती। इसीलिए आपको जो जिनके पास आप ले जा रहे हैं उनसे आप एक बार बात कराइए, तो हम उनके हाथ में वो रिस्पॉन्सिबिलिटी दे सकते हैं।
लेकिन मैम कागज हम कोई साइन नहीं करेंगे, पेशेंट तो आपकी केयर में, आप साइन करके अपनी जान छुड़वा लेंगे कि हम आपने पेशेंट हमें हैंड ओवर कर
हाँ.
दिया। ये तो गलत है, ऐसे थोड़ी ना होता है।
न-
आपके
वो
यहाँ
तो
तो
मेडिको लीगल
एक हमारा
वो
पेशेंट ठीक आया था, ठीक कंडीशन में आया था, आपके यहाँ पे पेशेंट की हालत खराब हो गई है और अब आप कह रहे हैं कि आप हमें साइन भी करके देने पड़ेंगे, तो ये तो उल्टी वाली बात
हाँ.
हो गई ना। बल्कि आप हमें साइन
साइन,
करके दीजिए कि भाई हमारी
साइन तो
गलती से
Then
गलती।
you
मेडिको
come with
लीगल
us, ma'am.
एस्पेक्ट्स है,
You
वो
come with
करने
us
पड़ेंगे।
to the other hospital and you hand over the patient to the other
हाँ
doctor.
ये ठीक है, ये ठीक कह रहे हैं।
लेकिन उनके शिफ्टिंग ऐसे नहीं हो सकता है ब्लाइंडली, पहले उनसे बात होनी पड़ती है। वहां से एम्बुलेंस आती है, वेंटिलेटर आता है, वहां से डॉक्टर आता है, तभी हम उनके हाथ में हैंड ओवर कर सकते हैं। वहां जाके अगर बेड नहीं है, डॉक्टर नहीं है, तो कहाँ पे देंगे?
नहीं
नहीं,
वहां
हमने तैयारी कर दी है.
हाँ,
We are ready.
तो इसीलिए तो बात कराइए, जिनसे तैयारी हुई है तो मैं बात करा के यस आई एम विलिंग टू
पर वहाँ
ट्रांसफर,
कोई
कोई
डॉक्टर
बात
बात
नहीं।
नहीं कर रहा है, वो पहले पेशेंट यहाँ ले आओ, हम आपके पेशेंट को संभाल लेंगे।
नहीं, ऐसे नहीं हो सकता है।
They are
जिसके
saying
हाथ
the
में
treatment
देना
is
है
not
उनको
adequate.
नहीं। वो तो आप सेकंड ओपिनियन ले लीजिए किसी से भी। मैं आई एम ओपन टू टॉक टू एनी डॉक्टर दैट यू ब्रिंग टू सी द ट्रीटमेंट।
थैंक
3
यू।
minutes up, ma'am. We can't fight more.
थैंक यू। So can I request
और
everybody to
एक्चुअली
come in? Yeah,
द
please
थिंग
have
इज,
your cameras on.
या एंड इन द थिंग इज यहाँ पे एक्चुअली स्माइल आ रहा था जो मुझे रियल में नहीं आएगा, तो मुझे ऐसे आई एम ट्राइंग टू स्माइल एंड आई एम लाइक ओके, ये तो लाइक यू नो रियली गेटिंग इनटू
पर
द ट्रू वे।
अगर सभी डॉक्टर आपकी तरह हैंडल करें तो मुझे लग रहा है कहीं वायरलेस होगा ही नहीं, कोई प्रॉब्लम होगा ही
नहीं
नहीं।
नहीं, पर इट इज एक्चुअली यू नो वो जो जो फीलिंग आती है कि यस ये काफी, ये सिचुएशन हम डेली हैंडल करते और कहाँ भेजे ना पेशेंट्स को, इट इज सो रिस्की।
हम्म,
ले जाते हैं लेकिन फिर बाद में उन अगर पेशेंट को कुछ हो गया इन ऑन द वे,
हम्म,
तो ट्रांसपोर्ट ऐसे हम लोग बात करके ही करते हैं कि who is taking the responsibility, उनको पता है ना what are they, because what happens is the mortality of that hospital will also increase.
हम्म,
So generally कोई hospital very sick patients लेते ही नहीं हो because they feel उनको यहाँ लाएंगे और डेथ यहाँ हो जाती है।
हम्म। True.
So the trend is not anymore to accept critical patients
Critical
without
care.
discussion.
Absolutely. So if I may ask everyone, I think first of all I'll ask Dr. Ravi and Dr. Kapoor to share what do you think Dr. Vaibhavi did effectively that really helped you to become quiet or accept her point of view.
And she explained very clearly the dangers involved in transporting the patient, that she's already very critical, and this could just worsen the situation, which made a lot of sense. That as it is, and it was very nicely done, 2 3 times willing to discuss, also her willingness to discuss if we want to transfer the patient, to talk to the other doctor. Or she said, you bring them here, I will hand over to the doctor. So that, not that she was just willing to say go. She was concerned. We could see that there was some concern.
Absolutely, absolutely. So, Dr. Kapoor, what did you feel? You didn't speak anything. I was hoping that you would give your government feel, how you experienced in the government sector.
This was so beautifully done. Really, I'm telling you, very well handled by Dr. Babari. Only thing which is really appreciating is she was really assertive. Though she was trying to give all her viewpoints and trying to understand their viewpoints, but it remained assertive, never became aggressive, never gone into passive mode. नहीं देखते हैं, कर लेंगे, कोशिश करते हैं. She was very assertive कि नहीं, आपको ये करना पड़ेगा. That's the way we should do it. Only thing which I think which should be done over there, which we always think about in counseling issues, to somehow understand the emotions of other people. One line, I can understand that you are very, very afraid, very, very scared about what's going to happen to my child. I can understand your emotions. That's very normal to happen. But at the same time, you should understand that what is the condition of your patient is or because of all our efforts, we are trying our best. We are not able to do this. So some emotional catharsis.
She did make a mention. I think she did make a mention. I understand your apprehension. I understand you.
Agreed.
Concerned.
Yeah. Agreed. Sure. So the beautifully done, ma'am.
Yeah, she really did a good job.
Yeah.
Thank you. So if I may ask all others, any other point besides what Dr. Ravi and Dr. Kapoor has mentioned?
Madam, may I?
Please go ahead.
I felt that she did it really well, so sweetly, that if I was that patient's family, I would have easily listened to what Dr. Vaibhavi had to say. But I still feel that, the doctor can be a little firm and say that the patient's family better trust, there is some kind of a trust in the hospital and the team of doctors. They would do their best. And is there some clause or something in the hospital that when you admit the patient, where the patient's family near ones have to sign, there must be some clauses, no?
Signing for what?
I mean, when you admit a patient, is the discharge so easy then in that case? I really don't know the laws.
Dr. Vaibhavi, please.
Okay, so basically, discharge is of course the relative's decision.
Okay.
They have the full right to say ki we can go. So they have the right. So we cannot stop them for sure. But at the same time, the risk associated with the transport is important for them to know.
Yeah.
So we ask them to speak to their doctors where they want to transfer. Then we talk to them, we tell them this is the situation. Sometimes that doctor also understands ये बहुत risky है transfer. Then they only tell these relatives that don't transfer now. They are correct. They are quite sick.
The line of treatment is going on fine.
And the line of treatment also, because all discussions are open. So whatever treatment is done, we share with them. So they also explain to them, because now their trust has gone to the other doctor. So we speak to them, they explain and they say, okay, idhar hi rehne do. So many times they say, we now know it's okay, you make them stay here only. Because sometimes if we start denying that, they don't trust, they lose trust more. That
also, Rashmi, even the assurance or the trust, saying that trust us, we will be able to save your patient, very wrong.
Wrong.
See, basically, there is a reason why, because every patient is different. And the treatment is absolutely by evidence-based, scientific. But the response given by the patient's body is different for all different patients. So we don't know truly how this response is going to be. Sometimes they look so bad and we feel that they may not survive, but they survive.
They fight.
And so we really don't know the outcome in our hands to do the best line of treatment is only in our hands.
So
But then that other point which was there, that we are not ready to sign, like suppose now you're doing the discharge, the procedure of discharge, then the patient's family need to sign, no? But as Dr. Indu was saying, that हम कोई paper नहीं sign करेंगे,
नहीं,
ऐसा
ऐसा
होता
नहीं
है?
हो सकता.
ऐसा नहीं.
that is where she asserted, if you observe, she asserted
Yes.
very clearly. One, she said that we can't let you go unless you sign the paper, because that's the protocol, that's
Yes,
the requirement. That's one thing. Second is, she did say, and she could have emphasized on it, that you can speak to your doctor and check with them that can you go without signing the document. So the patient party may not trust Dr. Vaibhavi, but when they will speak to the other doctor is definitely going to say the same. That no, if you are coming on your own, then you will have to sign that document, because you're taking the patient out of their care with your decision and not with their advice.
Exactly. They cannot take up. In fact, they will not be, because अगर patients बहुत sick है.
Yeah,
So
that's one part, because they will also not like to have a patient, because that's going to add to their
critical.
At this point, we have also seen, like, if in case the doctor who is treating the patient is not sensitive enough, and they say, नहीं नहीं ऐसे कैसे ले जा सकते, these all things really make it worse. So if they want to take it, their that decision is respected, but then they have to follow the whole process.
Yeah.
And I think
there's no problem.
Then the risk in taking, I think that requires little time and discussion, where you help them see the risk to the patient's life, the risk to the recovery. That's where they will understand the patient's welfare is at stake. And if you are able to help them see that there's little possibility of recovery or coming back, which you are on your own, you are putting at risk. So that also goes in helping them understand.
Thank you for the clarity.
And also, I think the idea of second opinion really builds a lot of confidence. That if you are open to second opinion, that means you are open to being validated by somebody if I'm giving the right treatment.
Yes.
So one question that I mean you would often hear from the patient parties, डॉक्टर साहब गारंटी दीजिए कि हमारा पेशेंट बच जाएगा. गारंटी मुझे ठीक है, मैं रखने के लिए तैयार हूँ, पर आप मुझे गारंटी दीजिए कि पेशेंट को कुछ नहीं होगा. This is a very tricky situation. So Dr. Vaibhavi, how would you attend if I threw that question to you?
I actually tell them ki, there is no guarantee of anything. If you board a flight tomorrow, and can you give a guarantee that everything will run smoothly, because there's so many things beyond our control. So किसी चीज की guarantee देना, it's not possible. So I tell them कि ये science है, and इसमें हमारे हाथ, डॉक्टर्स के हाथ बेस्ट लाइन ऑफ ट्रीटमेंट देना है, लेकिन जो उसका आउटकम है वो हर पेशेंट का रिस्पॉन्स के हिसाब से है, और हर पेशेंट अलग होता है. सो वो आउटकम हम गारंटी नहीं दे सकते, बिकॉज इट इज अप टू द पेशेंट नाउ टू रिस्पॉन्ड टू द ट्रीटमेंट. यस, और वो हमारे हाथ नहीं है, वो पेशेंट का बॉडी हमको टाइम टू टाइम बताता है कि ये ट्रीटमेंट वर्क हो रहा है कि नहीं. एंड इट इज अबाउट दिस मोमेंट. मुझे पता नहीं नेक्स्ट मोमेंट क्या होने वाला है. एट दिस मोमेंट आई कैन टेल यू दैट द रिस्पॉन्स इज देयर और नॉट देयर. बट अगर 1 घंटे बाद 2 घंटे बाद क्या होने वाला है मुझे अभी नहीं पता. So I tell them very critically that till 24 hours, अगर 24 hours ये patient बिना ऑक्सीजन, बिना ब्लड प्रेशर मेडिसिन, अगर सही से रहते हैं उनके पैरामीटर्स, then he is out of the storm. Okay. At present he is in the middle of the storm, जहाँ पे minute to minute changes are happening. At this moment हमें सिर्फ ये moment दिखता है, आगे का कोई भी क्षण में क्या हो सकता है अभी 24 घंटे तक बोल नहीं सकते. So I tell them to actually see every moment to moment for now, and the larger outcome, prognosis, will only be discussed after 24 hours if he remains steady.
Yeah. So I think, Dr. Vaibhavi, what you're saying is absolutely right. When they ask for guarantee, I think what we can guarantee is of following the standard treatment protocol.
Yes.
But I can assure you, whatever the standard treatment protocol is, that is being followed. If you want to take second opinion, I'm ready to give you a short summary of the patient's treatment. You can go and consult a doctor. And if they say that something more needs to be done, I'm open to even taking that what happened.
Absolutely.
So that kind of
Absolutely.
gives their confidence. But when you're giving example, I would say please be very careful about the example that you give, because sometimes the example can backfire and they may argument even on the. I mean,
Mm.
of course, when you're a very
Mm.
seasoned person, then it is very different how you give that example.
Mm.
Sometimes these examples, backfire and
Can backfire.
can do more harm. Okay, if
Something
I may
that
ask, yeah,
something that is relatable to them.
yeah,
Use
something that
an example, something that relates to them.
yeah. So if I may ask all others to share their what more did you observe in the role play that Dr. Vaibhavi did that you think she did effectively? Others, anything that we have not talked about and you have observed.
Can I speak, madam?
So yeah, please go ahead. Yeah, sure.
Although the conversation was effective and Dr. Vaibhavi did the best to clarify and convince the patient's relatives,
Yeah.
the point which I would like to put here is why the patient's relatives came to this decision of moving the patient from this hospital. Why they felt that the care was not adequate, whether they were not communicated from the care when they started, whether the patient's relatives were not kept in loop, what was happening with the patient. Although they seemed like Dr. Ravi Matani said, like they were anxious about the patient's situation. What made them anxious? Although the Dr. Vaibhavi did it very well to convince, but what happened since beginning?
So that means regularly
Communication gap.
Regularly updating the family is very important to allay this anxiety and this fear, and also prepare them for eventuality. See, maybe the same patient we lose in an hour. So their anxiety is not, something unrealistic. That's actually a very true concern, and they may actually face death in an hour or so. So I think you're right. Prognosticating the family, letting them know that the condition is critical. We are doing our best, but anything can happen. Keep your fingers crossed. We are keeping our fingers crossed, but we will keep updating you time to time. So updating plays a very big role. I think this is another lesson we have to take. And updating has to be done in a very, interactive manner, not just telling the parameters, but also asking them, what do you think? What do you feel? Have you seen the patient? What is your feeling? So a lot of time when they come back after seeing the patient, they have a realization the patient is deteriorating. The patient is not going to come back. The patient is not going to survive. So that realization helps in crystallizing or consolidating your interaction with them. But that was very good observation. I agree with you, Shiva. Any other point, Dr. Kapoor?
Here,
Yeah.
sorry. So here, actually, we use diagrams. We use pictorial to explain to them, because sometimes they don't understand the medical terminologies. They don't even know the names of the organs that are failing.
Yeah.
So some way drawing that also helps them understand, like the big picture, what's happening in the body. So that has actually worked quite a lot of times for me, that we draw and I show them.
Visualizing, they're able to visualize the damage. They're able to
Yes.
visualize the damage.
And then the next meeting, same drawing. Then we show what again. So it's like you build on that story pictorially for them to understand.
Absolutely. Thank you. So there's a question by Dr. Farha, if I may take that. Sometimes patient goes on arguing even after explaining repeatedly, then I think doctor needs to be firmer. See, it's not about being firm. It's first of all building connection with the patient's family. If you're able to build connection, then they will be in mood to listen to you. And when they speak, if you listen with intent and concern and empathy, they are able to sense that, okay, you are not refusing to understand their state of care. What we sometimes think, what I'm saying that has to be heard and agreed and accepted. But what about their point of view? So they are definitely, they'll be dissatisfied. डॉक्टर साहब ने अपना बोला, मेरी तो सुनी नहीं, मेरी बात का तो जवाब दिया नहीं, मेरी तो concern को तो address नहीं करा. So that means we have to see, is it a dialogue or it is a monologue? It has to be a dialogue. So a lot of good things even I observed, like I saw a lot of good non-verbals demonstrated by Dr. Vaibhavi, like she was nodding. To start with, she did not interrupt. She was listening patiently. She took their introduction. She gave her introduction so that they know whom they are talking to. Then she explained about the patient's condition. Yes, one question, why do you want to take it? That this is, I think this is in our, makeup, I would say. We are in habit of doing more talking. I would really, really advise, if you can bring this change in your way of interaction, ask questions, make them speak. I think this is one change we need to bring, because we are in habit of talking a lot. Ask them, like Shiv Ranjan said, ask, why do you want to go? What is your concern? So one, you will get to read their mind. Second, their emotions will get ventilated. And also they will feel, okay, somebody is addressing this concern. We do not look at the psychosocial perspective. We normally focus on the biomedical perspective, but we don't focus on the psychosocial. So why do you want to go? It could be financial reason. It could be that the hospital is very far, or it could be they are not happy with the treatment. It could be our behavior. It could be that we are not allowing them to see. These are all very minor things according to us, but it could be very big thing from the patient's party point of view. If you can ask for these things and find solution, a lot of their grudges would actually settle down. So we need to really even check them. Then I also saw that she talked about that condition that she's on high support system, so that means the condition is really bad, is not good. And then she used this word, my concern. Somebody's mic is on. If you can please mute your mic. Yeah. So when you use this word, my concern is this, it really builds connection with the patient family. Oh, you are concerned about me, about my patient. That really gives them a lot of satisfaction. Oh, doctor is concerned about my patient. My concern about your patient is that if you take the patient from here, by the time you will reach to the next hospital and the patient will be back on ventilator, it might take 2 to 3 hours. At this moment, exposing your patient to even an hours of risk is not a good idea. So my concern shows that I'm concerned about you. That was a very good, statement that you made. And then you said, I understand your concern. Even that was a wonderful thing. And that's empathy. That I know I can understand your concern. And then you said, I'm willing to speak to the doctor. I think this is one thing that's really, really, it's more like, the final word that really helps the patient family understand, oh, you're ready to speak to my doctor. And especially if they have anybody in the family who is a doctor. See, a lot of times they'll say, Doctor, mera bhatija na US mein hai. Ya Doctor, meri bhatiji jo hai na wo America mein ya England mein hai. जैसे ही हम ये सुनते हैं हमें इतना गुस्सा आ जाता है कि मुझे क्या लेना देना है अगर वो यूएस में है या वो. But we can make use of this opportunity. Acha, do you want me to speak to them? At the moment you will speak to that person will be your spokesperson. They will speak your language because they are happy that you are ready to talk to them, listen to their concern and tell them about patient's condition. I think this is one opportunity we should never miss. Being open to the idea of second opinion, being ready to give a summary. These are all very, very good ways to build, that confidence that we know what we are doing. We are sure of the work and we are open to getting second opinion. And I think it was an excellent job done by Dr. Babu. Most of the things you covered very, very well. So I really thoroughly enjoyed your role.
Thank you. I think I am also learning. Every day is different.
Absolutely, because every situation is different. Yeah. So Dr. Kapoor says, if they insist on taking the patient away, wonderful question. The last line should be, see, I think one, had it been my family member, I would not have moved the patient from here. Second, it's your choice. If you decide to take the patient from here, we will all cooperate with you. We'll try to facilitate your transfer. You can speak to the doctor in the other hospital, and if they're willing to take, you can check if the bed is available. We will facilitate your transfer. You just have to sign that document of LAMA that you are taking the patient with. And please do not mind if they take it. They may have 100 reasons. It could be financial. It could be there is nobody to look after. Maybe they can't afford. They have already spent a lot of money on the treatment, and they are not seeing any expected outcome. It could be anything. We don't have the right to stop the patient. Happily, with all cooperation, I would say facilitate your transfer. I think this is what is my understanding. Any other point? If anybody wants to add, I can see one question or statement by Dr. Ravi. Talking to the other day, doctor may become a problem. Not all colleagues are receptive. Many try to put you down. It's a different scenario nowadays. Not that this is an excellent idea. Dr. Ravi, I agree with you and I disagree with you. One, it's a big lesson for all of us to learn never to talk ill about our colleagues. I think for all of us, that's a very big lesson. What is that called? Jousting? What is that called? There's a term for it when we talk ill about our colleagues. So I think we all have to, refrain from doing this. And second is, if I'm doing my things right, that's very important. Communication and documentation. Following standard treatment protocols. These are the basics we have to follow if we want to be free from any problem. Even if somebody comes and checks my reports, I have done my job well, I have looked after everything. Why should I be scared of? Even if they say talk ill about me, you can always counter by giving a scientific evidence of what you're doing. So therefore, we are insisting evidence-based medicine, so that nobody can challenge the treatment protocol that you are following. And if you have that everything documented. But yes, this is one field we have that the other doctor might talk ill about me. But even without your consent, the patient party might go and consult another doctor, and you may not get to me. That risk is always there, whether you like it or not. That's beyond our control. So any other point from others who have been observing and listening? Dr. Sudarshan Joshi, anything you wish to add, sir? Yes, Dr. Vaibhavi, you wish to say something?
Yes.
Yeah, please.
So basically, the second opinion in continuation with Dr. Matani's query that it is risky to kind of, take an opinion. Now, what we have started as a practice in our hospital, I would like to share so that it will help everybody. Even if we take an opinion, the relatives want to take an opinion, the doctor normally visits our hospital, sees the patient because they are the ones who are going to take handover from us. And if there is any query, like, if they feel, oh, this treatment should have been done or something like that, we ask them to actually document in the paper. And nobody does that. They just might say that, Are, ye karna chahiye tha. So we tell them, okay, you can write in that sheet. So they never write because it is an opinion. Scientifically, if there is anything missing, we tell them you can write that this is your consultation shows this, but they don't.
Yeah.
Because so
they
we
will
have
hesitate.
started.
Yeah, they will hesitate documenting their.
Yes,
Yeah.
they don't
But they can
document.
be
They just
challenged.
say.
Yeah.
So
I
we
think
ask them, you write then in that case, but they don't write. So this is where we have started now keeping complete honesty that this is there, papers are there, you see. If you feel anything, you can discuss, let us know your opinion, what anything more has to be done, so that we take them on board as a co-treater, and then later on we hand them over.
so good. That's a good idea. Very good idea. Dr. Joshi has written, the moment patient goes into critical care, patient starts keeping sick. Absolutely. See, they are desperate. They want to save the patient. So they want to go for second opinion. And I think we should not mind that. Rather, they will be satisfied that they did everything possible to save the patient. Now, this Padma, who is with us in the program, her mother is not well. I just checked with her today morning. How's your mother? And she said she's not well and she's in critical condition. Now, she asked, that can she get a second opinion? I don't think she would have got it because it's not easy to get second opinion. People are not willing to give. People are not, they don't come forward. As you're saying, that they hesitate commenting on somebody's treatment. They may say something at the back, but they don't, come out and talk about that. I completely agree with you. Yeah, Dr. Ravi, I think you wish to say something. Go ahead, please.
Yeah. Ma'am, it's not about critical care, but sometimes we have patients where, the prognosis is very poor. They come with that disease which has no real treatment. And I have always told them that, this is what it is. We explain the prognosis and before, I say that, there are so many people dealing with this. You take a second opinion, I always tell them two heads work better than one. Maybe, somebody, he may think of something else which is, different.
Yeah.
So, and the patients are very happy about it. We have these, WhatsApp group, Retina group,
Yeah.
UVA group, and
Yeah.
we share the images on the group and we say we will take. So we also tell them that, two heads work, many heads work better. We'll
Wonderful.
try everything to make you, to see what we can do for you. And they are very happy.
Yeah. In both ways, it helps. I think it upgrades our own knowledge also, because we may be missing on
Yes.
something. Netflix has one series. I saw a couple of its episodes, and it was, you put your. I mean, the organizers would put your case on Netflix and would ask people to give their, it could be patient, it could be doctors, it could be even allied sciences, who would give their opinion. Either they have seen a case, or they themselves have suffered, or somebody has treated across the world. And a lot of untreatable kind of conditions got resolved because they got input from so many people. I think that's the beauty of media sometimes, that helps to. And there's that. I think we are not gods. We don't know everything. So why not have more people on board to share their thoughts? Thank you, Dr. Janvi. I think you wish to say something. Please go ahead. Yeah.
Yeah, ma'am. Just wanted to add that second opinion is basic right of every patient. So obviously we do encounter such scenarios. So what we have started doing in our hospital, especially with critical patients and multiple disciplines which are involved. So we have something called as a multidisciplinary counseling, which all the doctors, we try and coordinate. They are there. We even ask the patients that please call whoever are your important decision making relatives. We have one representative from the administrative side also, who help along when once the doctor does clinical counseling. There is someone who talks about financial counseling as well, because both are important, clinical aspect as well as because everything in ICU is linked to so much of expenses. And recently we even added, if possible, a psychologist with us also. That is just because so doctors cannot give a lot of time and everything. They come for these meetings. We have it as a full team, maybe 8-10 people where they discuss. And the psychologist just takes it from that point onwards. If it is like really critical or end of life situation or something, a shoulder, additional shoulder, but we make a part of this team. So she's aware of what discussions have gone. So this is what something which we have tried. Of course, we audio video recorded with their permission. So we have it for future use for medical legal purposes. So this is what we have tried to do.
That's really nice. That's really nice. So I did a program for Reliance Foundation Hospital, Bombay. It was a 10-session program. We did online, and then I went for one day and concluded the program. And this is what exactly they are practicing. They have a psychologist on board who would actually coordinate with the patient's family and look after their, psychosocial needs, so that they can be, those aspects are also looked after. I think slowly we are having people from mental health on board, and that's very important. That's very, very, very helpful. Yeah. Thank you. Thank you. So the whole idea of this role play was one, of course, how do you handle such situation? And then also was to understand assertion, which Dr. Vaibhavi did very well. Nowhere she was disrespectful, nowhere she was rude, nowhere she acted impatient, nowhere she was aggressive. And I think that is actually real sense of assertion. Assertion does not mean being authoritative or rude or intimidating or loud, but it is saying what you want to say in a very respectful, confident manner, without being rude and aggressive with the patient party. So here I'm going to show you 4 small videos. They are my in-house videos. And I'm trying to show you all those 4 communication styles that we discussed in the last session. That is passive communication, passive-aggressive communication, aggressive communication, and assertive communication. So it is the same case, but something simpler than what we have taken just now. This was a case in ICU, but the case that I have taken is that there's a patient in the ward and the patient's family members want to take them in. So let me show you those videos one by one and discuss them. I can see some comments coming in. Rehan says, excellent input. Thank you, Rehan. I think it is a rich learning when everybody is participating and sharing their experience. Dr. Vaibhavi, I think, okay, Dr. Vaibhavi has written amazing input by Dr. Janvi. Shivraj says involving patient relatives in the care is important right from the beginning if the patient has no capacity. I completely agree with you. I completely agree with you. I think this is one change that's still waiting to happen in our country. We really need to take patient's family on board. That would not only make our task easy, but they will feel empowered. They will feel that they were the decision makers. So the onus of the outcome does not completely fall on the doctor or the treating team, but it is divided amongst all of us. That's very important. And the last question that we should ask, what do you say? What do you want? What do you feel about it? When you ask these questions, definitely you get, answers. Most likely they'll say, yes, what you're doing is right. I think what you're suggesting is okay. But that answer should be earned. That answer has to be explicitly received from the patient party. That effort has to be made. And we can't just take it for granted that I will decide on the patient's behalf and they'll just have to listen. It may take a little longer, but it really saves you from a lot of hassle. Thank you for everyone's input. Thank you so much. Yeah. So I'm going to show you the videos. Give me a second to share the screen. Okay. So the first video is passive communication.
मैम मैम बेड नंबर 7 पे पेशेंट जाने के लिए कह रहे हैं कहाँ दूसरा हॉस्पिटल जाने के लिए कह रहे हैं उनके जो रिश्तेदार हैं क्या कह रहे हैं मैं डिस्चार्ज करता हूँ दूसरा हॉस्पिटल जाएंगे वो जो उनका बेटा है जो उनके साथ जो है ना वो कह रहे हैं दूसरा हॉस्पिटल एक बार आपसे बात करा बात कर जाने दो क्या करना है कौन से कपाई करेगा छोड़ो करो डॉक्टर राकेश को बोलो उसकी डिस्चार्ज स्लिप बना दे आप अपना बेड क्लियर कर देना ठीक है बना दो डिस्चार्ज स्लिप बनवा दो
I think there was slight lag in the video. Okay, so what did you observe in this behavior, in this video? What was my stand in this video? Am I audible? So this was a video on passive communication. I tried to demonstrate passive communication where I did not take any stand. I did not make any effort to talk to the patient's family. I did not try to help them understand why the patient needs to be here or why not move the patient. So I can see it was okay, careless, absolutely, not much concerned, annoyed, non-reactive, just send them away. So that means a lot of time we do this, and especially when the patient's party wants to go lama, we have seen that we normally say, let them go, let them, it's okay. I mean, we don't make, and yes, indifference. I think that's the very right word for the behavior. It was indifferent. That means I don't care, let them go. So if that's my attitude with my patients, you can well imagine, and in the long run, what is going to be my patient satisfaction? What is going to be my satisfaction? What is going to be my team satisfaction? So, I mean, that was a sample of passive communication. Now, let me show you the second communication style, and that is passive-aggressive communication style.
मैम बेड नंबर 7 के पेशेंट जाने के लिए कह रहे हैं कहाँ जाना है दूसरा हॉस्पिटल जाने के लिए कह रहे हैं डिस्चार्ज कर दीजिए दूसरा हॉस्पिटल कौन कह रहे हैं उनका बेटा साथ में वो जो हर टाइम उनके साथ रहता है, वो है ही बदतमीज, वो बिल्कुल बेकार आदमी है। हर वक्त कुछ ना कुछ उसको नया ही सोचता। अब क्या कह रहा है वो?
डिस्चार्ज करके हम दूसरा हॉस्पिटल लेके जाएंगे।
तो वहां जाके क्या इनको बहुत बढ़िया कुछ वो मिल जाएगा क्या? यहाँ पे इनको क्या तकलीफ है? क्या कह रहे हैं यहाँ पे, क्या दिक्कत है उसको?
कह रहे बस हमारे डिस्चार्ज कर दीजिए, हम दूसरा हॉस्पिटल जाएंगे।
नहीं तो वहां पे क्या, यहाँ पे इसको क्या दिक्कत आ रही है? कुछ बता रहा है कि क्या क्या प्रॉब्लम है उसको?
नहीं ऐसा तो कुछ बताया नहीं।
कुछ बोला नहीं? अरे ये शुरू से ही ऐसे ही बोल रहा है, ये वहां तंग करने वाला बंदा है, किसी काम का नहीं है। भेजो, ऐसे बंदे से क्या करना है हमने? कोई और लड़ाई करेगा, जितनी देर ये यहाँ रहेगा तंग ही करेगा। मेरे पास आता है, कभी कहती है सिस्टर ऐसे कर रही है, कभी कहते हैं जी सिस्टर वैसे कर रही है, कभी कहते हैं जी पर्दे नहीं ठीक यहाँ पे, कभी कहते हैं जी एसी नहीं काम कर रहा आपका। बार बार कंप्लेन ही करते हैं। भेजो इसको और डॉक्टर राकेश को बोलो इसकी वो बना दे।
बात कर लीजिए।
क्या बात करनी है? बदतमीज आदमी है, जाने जान छूटेगी। कुछ बोलना मत उसको। उसको कह रहे हैं ठीक है बना के देंगे। डॉक्टर राकेश को बोलो उसकी डिस्चार्ज स्लिप बना दे और बिल क्लियर कर देना अपने। भेजो, जाने दो। ऐसे लोग जाए ना ही रहे तो अच्छा। सारा दिन सिर खपाई करनी पड़ती है। ठीक है, तुम्हारा क्यों उतर गया? जाओ जाओ जाओ, जाने दो।
What did you observe in this video? This was on passive aggressive communication style. So you can comment on language, body language, tone of voice. Annoyed, yes. Ego, terrible doctor, absolutely. Absolutely. Super aggressive, yes, but not acting aggressive with the patient. See, passive aggressive people will never come out of their anger in front of the person. They'll always talk at the back. And you saw, I was talking ill about the patient at the back, not talking to the patient. Passive aggressive people will not confront the person, but they will sabotage. Self-centered, okay, assumption about the patient. Yes, again, negative assumption. All, I mean, they are demanding, they are too critical, being judgmental. Yes, being judgmental. Oh, this patient is useless, this patient is very demanding, this patient is very irritating. And we pass these labels very quickly to the patient and their family. So this is passive aggressive. So I'm not trying to handle the situation, but I am annoyed about the situation, not ready to directly deal one-on-one, but I'm just talking ill about it. So if you look at the language, the body language, the tone of voice, everything was negative and not helpful in any way. So let me show you the third video, and that is on aggressive communication. So how you handle similar situation in an aggressive way. I've taken the same situation to help you see the 4 different behaviors.
मैम आसू, मैम बैड नंबर 7 के पेशेंट जाने के लिए कहते हैं।
क्यों?
वो डिस्चार्ज मांग रहे हैं, कह रहे हैं छुट्टी करके हम दूसरे हॉस्पिटल जाएंगे।
फिर क्या तकलीफ है उसको?
वो कह रहे छुट्टी करते हैं, हम दूसरे हॉस्पिटल जाएंगे।
यार बहुत ही पागल आदमी है। हालत पेशेंट की इतनी खराब है, छुट्टी करो, रास्ते में कुछ हो गया तो क्या करेंगे?
उसके साथ जो पेशेंट है वो कह रहे हैं कि हमारा डिस्चार्ज है।
उसका जो बेटा है जो उसके साथ हमेशा बैठता है, बहुत ही बेकार आदमी है। जब देखो इसको, पहले तो इतने नखरे इतने हैं, कभी एसी काम नहीं कर रहा, कभी ये नहीं काम कर रहा, अब छुट्टी कर दो, छुट्टी कर दो।
आपकी बात करा दो,
भेजो उसको, जरा सही करो उसको, भेजो जरा। क्या तकलीफ है भाई, क्या हुआ है?
मैम डिस्चार्ज कर दीजिए।
तुम्हें उनकी हालत पता है इस वक्त क्या है?
बहुत दूर पड़ता है, आने जाने में दिक्कत होती है, इसके बाद डिस्चार्ज कर दीजिए।
नहीं तो हॉस्पिटल तुम्हारे घर के पास ले जाऊं, डिस्चार्ज कर दो। उनकी हालत इतनी खराब है, रास्ते में कुछ हो हवा गया ना इधर के रहोगे ना उधर के रहोगे। ज्यादा दिमाग मत चलाओ अपना। इलाज करवाना है तो शांति से करवाना चाहिए, ऐसे नहीं कि इधर भागो उधर भागो।
इधर आने के लिए ऐसा लगता है, और इधर आते ही बहुत ज्यादा बिल हो जाएगा, तो पैसे है नहीं हमारे पास।
तो पहले ही सरकारी में चले जाना था, यहाँ आने की क्या जरूरत थी? आधा अधूरा इलाज करके अब जहाँ जाओगे तो वो लोग तो कहेंगे ना जी ठीक से इलाज नहीं करा उन्होंने, मेरा भी नाम खराब करोगे, रास्ते में पेशेंट को कुछ हो गया और मुसीबत हो जाएगी।
मैं डिस्चार्ज कर दीजिए।
भैया बहुत ही बेकार आदमी हो तुम। डिस्चार्ज तो मैं कर दूंगी, पर दोबारा मुड़ के मेरे पास बताना। ये कोई तरीका नहीं है इलाज कराने का। अपने पेशेंट का भी नुकसान करोगे और मेरा भी नुकसान करोगे साथ ही साथ में। हमारा आदमी है। सिस्टर, इनकी डिस्चार्ज स्लिप बना दो और बिल क्लियर करो इनका और भेजना इनको। जाओ और दोबारा मुड़ के मत आना मेरे क्लिनिक में। पता नहीं कहाँ से लोग आ जाते हैं।
So we don't get to see this behavior now very often, but we are mostly passive aggressive. Overtly, we don't shout or talk ill directly to the patient, but internally we are full of grudge. Am I right? So what exactly did you observe in the behavior or tone of voice or overall interaction? You can write in the chat box. Abusive, rude, I think. Yeah, I was using some words, pagal aadmi hai. I mean, that's an abuse in a way. Rude, yes. Threatening, absolutely threatening. Considering superior to others, yes. Bilkul okay for a few times. Zahir. It is never okay. See, that's where we have to learn. If you think the other person is not accepting my point of view, I don't have the right to cross my professional line. Patient may not agree with you. Even if you're talking in favor of the patient's welfare, they may not agree. That is where we have to draw a line, that we can't cross a line. There's a professional conduct that I need to maintain. If they comply, if they come for follow-up, if they take treatment, or they don't do it, I can't shout at them. So you got to be careful, because this is something, this can escalate. Now, if I'm rude to the patient, today patients write Google reviews about you. I was reading about, yesterday, just by chance, I was reading Google reviews for one of the gynecologists. I was very sad to hear those, read those reviews. And how sad it is. Somebody has put in years of effort to be there, and then somebody writes bad reviews and just maligns somebody's image. So you got to be very careful. Now, today is not the time to become aggressive with people, because you never know where you might end up. It's very, very unsafe, very, very unsafe. So let me show you the fourth communication style that is helpful, and that's what we are trying to recommend, that we need to really be very professional in our way of handling, and also caring, compassionate with the patient. This is assertive communication.
मैं राजा हूँ इसमें। मैं बस application जाने के लिए जाए।
कहाँ जाना चाहते हैं?
दूसरे हॉस्पिटल।
छुट्टी के लिए गए हैं?
हाँ जी।
जो उसका बेटा जो साथ में वही होता है उसका। भेजो उसको, मैं एक बार से बात करूँ। नाम है ना आपका? आप उनके बेटे? क्या हुआ इधर?
डिस्चार्ज कर दीजिए।
कहाँ ले जाना चाहती है?
किसी दूसरे हॉस्पिटल में जाने, जो अपने घर के पास में होगा। वहां से आने में बहुत दूर पड़ता है, और जो पैसा होता है आने जाने में खर्चा बहुत हो जाता है।
देखो बेटा, अगर आप कहोगे छुट्टी कर दो, मैं कर दूंगी, मुझे कोई दिक्कत नहीं। तो मैं आपको ये बताना चाहती हूँ कि इस वक्त उनकी हालत जो है वो लेके जाने वाली नहीं है। क्योंकि एक तो जैसे यहाँ से अगर आप लेके जाओगे तो रास्ते में एम्बुलेंस को लेके जाओगे, कैसे होगा कुछ नहीं कह सकते, क्या सिचुएशन में कुछ नहीं कह सकते। मतलब हालत इतनी अच्छी नहीं है, ठीक है। थोड़ी भी ठीक होती तो मैं कहती चलो ले जाओ, कोई बात नहीं। तो एक तो सबसे बड़ी बात ये है। दूसरा ये देखो बेटा, जैसे पिछले हफ्ते से हम लोग इलाज कर रहे हैं, तो हमें काफी हद तक उनके बारे में पता है क्या उनकी कंडीशन है। अब नए हॉस्पिटल जाओगे, नए सिरे से वो इलाज करेंगे। मैं बेशक तुम्हें पर्चे बना के दूंगी, उनका सारा डिस्चार्ज लिख के दूंगी, जो ट्रीटमेंट करनी है। तो फिर भी एक होता है, डॉक्टर जो ट्रीट कर रहे होते हैं उनको पता होता है कि इस वक्त इनकी किस दवाई से इनको फायदा हो रहा है, क्या इनको नहीं सूट कर रहा। नई जगह जाओगे तो फिर वो नए तरीके से सारा हैंडल करेंगे। तो देखो एडवाइजेबल तो नहीं होता बार बार डॉक्टर चेंज करना, और मुझे ऐसा भी लग रहा है कि पिछले 2-3 दिनों में थोड़ी, अगर आपने नोट करा तो उनकी कंडीशन में इम्प्रूवमेंट भी हुई है।
इम्प्रूवमेंट तो हुई, बट उनकी पैसे वाली प्रॉब्लम आ जाती है वैसे।
देखो बच्चे, ये तो मैं मानती हूँ कि प्राइवेट में तो खर्चा आता है, अगर जहाँ भी लेके जाओगे वहां भी खर्चा तो आएगा ही आएगा, ऐसा तो है नहीं कि फ्री में हो जाएगा। अच्छा, सरकारी में अगर जाओगे तो वहां पे आपको पता है वहां पे इतना पेशेंट होता है कि आपके पेशेंट को बेड मिलेगा नहीं मिलेगा कुछ गारंटी नहीं है ना। देखो मेरे से पूछोगे अगर तो 2-3 दिन की बात और है, जहाँ इतना सह लिया ये भी आप कर लो। बहुत मुश्किल है, लेके जाना चाहते हो फिर तो बेटा मैं जिद तो नहीं कर सकती तुम्हारे साथ, तुम्हारा पेशेंट है, तुम्हारी फादर है, तुम्हें डिसाइड करना है कि क्या करना है, जो भी करना था तुम कर सकते हो। मैं कहूंगी ये कि घर पे एक बार सलाह कर लो, अपने बाकी जो लोग हैं उनसे बैठ के सलाह कर लो, क्योंकि मेरा कहना है कि सिर्फ 2-3 दिन की बात है, जहाँ हफ्ता निकल गया तो 2-3 दिन की बात है। फिर भी कहोगे तो मैं कर दूंगी छुट्टी, मुझे कोई दिक्कत नहीं, मैं पर्चे बना दूंगी, पता कर लो जहाँ बेड है, इतना खर्चा कम आता है, फिर आने ले जाओ।
वैसे आपने तो सही कहा, वैसे एक बार जाके घर में मैं डिस्कस कर लेता हूँ मैम, और पता करता हूँ कि 2-3 दिन की और बात है, और इम्प्रूवमेंट भी अच्छा हो रहा है उनका, तो शायद हो सकता है कि खर्चा थोड़ा एडजस्ट कर लेंगे तो हो सकता है सही हो।
देखो बेटा, हॉस्पिटल में खर्चा तो होता ही है, ये तो है नहीं कि फ्री कहीं काम होगा। वहाँ सरकारी में जाओगे तो वहाँ टाइम ज्यादा लगेगा या बेड नहीं मिलेगा, प्राइवेट में जाओगे तो 19-20 का फर्क आएगा, ऐसा नहीं क्योंकि जमीन आसमान का अंतर है। फिर भी आप सलाह कर लो, मुझे बता दो, ठीक है?
थैंक यू।
अच्छा,
So I hope you got some idea that if you are able to build rapport with the patient, understand their concern, address those concerns, what exactly did you observe in this? Anything that you think I did right to connect or conversate? You can write in the chat box. Yeah, understand their problem. Calm conversation, yes. I think that's what I wanted to demonstrate, that I was not aggressive. Caring and compassionate, yes. Addressed properly, yes. And if you observed, I was respectful towards the boy. I was, even if he was much younger to me, I was not like trying to show my age or my experience or my position. Empathy, yes. Gave all the information for decision making. Absolutely. I think that's what I was trying to demonstrate. And if you looked at the body language, tone of voice, way of listening, I was trying to build rapport with the patient and be on the same page, agreeing with patient's viewpoint and then explaining what is being done. Yes, I think this is what I tried to show in this video. And this is what is assertion. Not that we agree with their point of view or we don't or force them to agree with us, but you give your independent point of view in a very calm and respectful manner. And that's what is the need of PR. I think wherever you are, whether you are in lab, radiology, ICU, front desk, wherever we are, I think this is the conduct we all have to maintain with our patients and even with our fellow colleagues, with our doctors, with our nurses, with our non-clinical staff, with everyone. I think this is the conduct that we need to have. So this was just to give you a taste of different communication styles and how assertion is a very, very helpful and healthy communication style, which slowly must practice not only in professional setup, even in personal life. It's a great, great way to connect even with your family and friends. Any questions about what we have discussed? Should we move further from here? Okay, supporting offer to whatever decision they find. Yeah. So even in case if he would have said that, no, we want to take, I mean, it's our duty to facilitate that happening. So this is a learned thing. I think assertion is a learned thing. It doesn't come automatically. It's a mindful process. You have to really condition yourself to be okay with if they don't agree with you. And you save yourself of so much of agony and unnecessary aggression. Okay, so second topic, as I said, that I want to bring in here is how to handle aggressive patient party. So I will not be doing a role play on it. I wish we had time to do that role play. Maybe we'll be doing a couple of role plays and we'll do breaking of bad news and disclosure of medical error. there we will be experiencing aggressive patient party because they will act aggressive with us. But I want to specifically cover one topic, and that is how do you kind of handle aggressive patient party and ultimately prevent violence in your workplace. So I'm going to share the presentation with all of you and discuss around this topic. So this is saying that it always storms before it rains. That means whenever there's a problem coming in, there's always a sign of that problem. The idea is how vigilant are we, how careful we are in identifying those signs, those indications, where you know that the situation can turn into an aggressive reaction coming from the patient party. And that can actually, prevent a lot of hassle that comes with it. So I did talk about this term called triaging. We all know about triaging as a medical triaging, but I say like medical triaging, we have to learn social triaging. So identify people who may not have much social role, but they may have a lot of nuisance value. And that's what we really need to be able to identify and handle them with care. Not that we become aggressive or upset or annoyed with them, but we know how to, minimize the damage, how to really handle that situation. So as I said earlier also, that crisis moments will never happen all of a sudden. Mostly there always will be a warning sign. And if you can, identify those warning signs and intervene at the right time, you can actually save the situation. Before we move further, I think I would like to, understand and discuss what typically causes anger in our patient. What exactly do you think happens that the patient gets angry? Can you write your answers in the chat box? By the way, why do patients get angry? Okay, time wasters. If we don't meet their expectations not getting fulfilled, absolutely. What more? We fail to make them understand, okay. When not cordially received, yes. When we are disrespectful, slow or poor response to treatment, okay. No adequate information to them about what's happening to their patient. So there's communication failure, there's a communication gap. So these are very, yes, not transparency. There's lack of transparency, absolutely. Trust issues sometimes, yes, even that could be one of the reasons why people get angry with us. So if I may club all of these, okay, lack of connect, lack of transparency, absolutely, I completely agree with you. So if we club all of them, we can actually understand it from the Mark Dworkin's explanation of the 4 phases of anger that starts from 4 eyes. So when one has a palpable sense of injustice, injury, invasion, and intention, you will see anger coming, reaction coming from the patient. So what is the first eye? That is injustice. So whenever the patient or the attendant has a feeling that some injustice has been done to me, or somebody has been unfair to me, or I'm a victim of the situation, that really fuels anger in the patient. So that's the first reason for the patient becoming angry. The second angry eye is injury. So whenever patient feels that I have been disrespected, discarded, or ignored. So if you can see a couple of the pictures that I've shown here, in the first picture, the patient is wearing a gown, but patient is almost like half naked. In the second picture, you can see the patient is made to lie on a table and everybody is looking at the patient as though it's a dummy and it's something like, something that they can look at or stare at. So that's a kind of a disrespect to the patient's privacy or respect to the body or autonomy. And also when there's a sense of insult and humiliation along with injury. It could be a psychological injury and at times it could be a physical injury. For example, to a very aggressive patient, very, very, not only aggressive, but patient who is not manageable. Sometimes we all use physical restraint, but the intention is not to harm the patient or hurt the patient. The intention is to control the patient's movement. But at times when we do it in a rude manner, the family and the patient feels that we have been insensitive to the patient's suffering. The third I is about invasion. So as it is when the patient is in the hospital, the patient's autonomy, patient's freedom, patient movement is already, is restricted. Over and above that, for example, if they're always under the camera or, they are made to use urinal or bedpan. So that restricts their not only, movement, but also it's more like a threat to their bodily or psychological integrity. So all that is more like, invasion or disruption of their privacy and their personal space. The last angry I is intention. So whenever there is an energy and determination to do something about if there's a feeling that there has been injustice or there has been injury or there's an invasion, so that actually ends up into or boils down to acting out where there's an intention to, take out that anger. And patient is actually ready, either reflexively or purposefully, to change the status quo because patient feels that something wrong has been done to me and I have full right to react to it and give it back. So if I may club everything that happens in this situation, we can say there are 4 stages of crisis development and management. So at every stage, we have an opportunity to intervene and mitigate the situation, provided we are vigilant and we know how to handle that situation. The first stage of crisis development is anxiety. So that is the stage where you can make out that there is something not okay. I've written it again, crisis moments just don't happen. There are always warning signs. And if you can identify those warning signs and you can intervene at that situation, you can actually control the situation. So specifically in these situations, how you react, how you handle, how you manage will decide whether you're able to mitigate the situation or you flare this up. For example, when they come and talk to us in an aggressive way, and if we also react in an aggressive or rude manner, we are going to aggravate the situation. And these are the following, 10 steps that I'm going to discuss here that can help us to, mitigate this situation. So the first one, as I said, be vigilant and watch for the warning signs. And it's not just the duty of the doctors or the nurses. Actually, we need to train each and every hospital staff to be vigilant and look for the warning signs. They can actually act as your ears and eyes to tell you that there is something, this patient looks dissatisfied, or this family members appear dissatisfied, or they are talking ill about the hospital or about the staff or about the treatment. So you get those, inputs from your staff who can tell you that these are all red flags. And we really need to train our staff to be vigilant of this so that they can come and report to the right person to proactively mitigate this situation. So whenever you see anybody, acting little aggressive or beginning to challenge your authority or the facility or the hospital staff and becomes, belligerent, that's an idea that this patient or the family can further become aggressive and become rude. So the best way at that moment is to segregate them from the crowd. Usually either we ignore their anger or we don't pay any attention, thinking that let him talk, let him be rude, let him shout, I don't care. But that's the time actually to segregate them from the crowd and take them to a safe place to express, make them sit and talk, and then offer them a glass of water and ask them what is their concern. So if you don't segregate, the risk is people who are overhearing this or they are observing it, there will be few who will align with this person. And this situation can turn into a, more difficult situation to handle. As we discussed in the last session also, ask, observe, and listen to them to understand what is the reason for their anger or aggression. 93% of the communication is non-verbal. If you will observe their body language, if you see their tone of voice, you will get an idea what they are trying to say or what they are feeling or what they are thinking. Similarly, we really need to be mindful of our own body language and tone of voice. We really need to stay calm so that we don't aggravate the situation. Let them speak so that they can ventilate and they can express themselves in a complete manner. Don't try to correct them even if they are saying something wrong. I'm not saying that you don't have to correct them or you don't have to kind of give them the feedback that this was not appropriate, but not immediately. Wait for them to complete and then you can say what they were saying was not correct or not right. Don't be in a hurry to justify yourself. A lot of time they may blame you for something that has happened with them. Like for example, the last role play that we did in the last class about the MRI machine going out of order. So you may want to justify by saying, how would I know the machine will go out of order? The machine is under annual maintenance contract. The engineers come on time and do the maintenance, but still sometimes machines go order or electricity failure or something like this. So, but if you try to justify at that moment, that's not going to help. Let them say, let them, whatever they want to, speak, let them complete. And if they're saying something, don't give them a feeling that this is something very petty thing and need not be brought to the discussion. So when they are saying something, really listen. It's important to clarify their messages. Sometimes when they say something and if you think you don't agree, asking them to, can you explain this further? Can you tell me what exactly you want to say? So that will give them a feeling that, okay, not only that you're hearing, but you're trying to understand. That will also give you an understanding of the feelings behind the facts. A lot of time there is hurt, there is anxiety, there is sadness, there is panicking. Those feelings you will be able to identify once you will allow them to speak about and tell what they are feeling or experiencing. At this moment, asking reflective questions will help you greatly understanding what they are experiencing, because that's what is going to give you an idea in their mind. As we discussed last time also, every time they speak, they're going to talk about their pain, their suffering, their plight. It's important for us to be empathetic. Put yourself in their position. Don't judge them. How can you be so rude? How can you be so aggressive? How can you be panicking? What is there to be anxious? Because that's something that they haven't created, but that happens in a situation. So even if you think that those feelings are unjustified, but these feelings are real to them. So we can't say that these are unreasonable feelings and not required in this situation. And it's important to not only pay attention to them, but acknowledge, normalize, and generalize, because that's what is going to give them a feeling that you are not only listening, understanding, but also accepting them as it is. Unless they are the feelings of aggression or violence. And then saying something like, I can see you're very upset, you seem to be really frustrated. So that shows that you are able to read their feelings and you're acknowledging and you're not reacting to it in an aggressive manner. Like last time we discussed, apology works even when it is an aggressive reaction. Some of you may feel that if the person is acting aggressive, we don't have to apologize. But very honestly, it is apology for the inconvenience, unless we have done any harm to the patient or something that we have gone wrong. But usually if it's the apology for the inconvenience, they calm down when we are ready to apologize for that. Two meanings of the word I'm sorry. This we had discussed last time, so I'll not spend much time. I think the first expression is expression of compassion. I'm sorry that this happened to me. I'm sorry that you had to go through this suffering. But the second sorry is when something wrong has been done by us. It has caused inconvenience, harm, damage, or loss. Then of course it's an expression of responsibility, and both are important. Instead, it's also important when you are talking to them, when you're trying to understand, their concern, and when the cause of aggression is beyond your control, that's where you can help them see your perspective. For example, if the machine has gone out of order, or there has been some emergency and the complete team had to be, moving to another location, and the doctors or the other members are not available. So that's where maybe you can help them see your perspective. But again, how much ready they are to understand that, we have to really evaluate in that situation. Patients, when they act angry, please don't take their anger personally, because they are not just angry with you, but maybe they are angry about their other issues and concern. Focus on the solution rather than the patient's behavior. Try to take their attention to what they want and how you can resolve the issue. Avoid being defensive and find out what does the patient want. Usually when you are able to find out what do you want, what will help them, what will reduce their suffering, and if you take your attention to that, most of the anger can be handled in this situation. If you are able to manage this well, usually you will be able to control the situation. But in case if these things are not addressed, to their anger, if we are reacting aggressively, or we are focusing on their behavior rather than the solution, or we become aggressive and defensive with them, usually things move to the second stage, and that is where the patient becomes defensive. So when the patient becomes defensive and aggressive at the same time, the problem is that there is increased emotionality. The anger has overpowered, the emotions are overpowered, rationality you will see going down, logic will not work in that situation, because the patient is losing touch with the reality. You will see them, raising their voice, their body language will be aggressive. You can see the tone of voice will go loud, and body language also will show, anger and aggression on their face. They'll be pacing up and down and shouting and using different ways to intimidate others. The person may actually start, challenging you or the authority that you are representing, and they may become belligerent. So this is this stage 2, where they are now, their anger and aggression is rising. It's going out of, how do you handle it? How to contain that situation? One, we can provide guidance. Like, for example, when they're shouting or they're, using high pitch, high tone voice, if you tell them, see, I'm ready to help you, but you really need to calm down and talk to me and tell me what exactly is your concern. So that means you're guiding them about their behavior, you're asking them to calm down. You can also give them directions. For example, if you think that they are not satisfied with you, even whatever discussion you're having with them, and they really want to address it, you can tell them that in case if you are not satisfied with my answer, you can meet our senior officer, you can give me in writing, I can escalate your issue. So you can even, or for example, if it is ICU or OT or labor room, and if they are making noise there, maybe you'll have to actually tell them, see, whatever concerns you have, but you can't be making noise here. I can't allow you to shout, in this place. There are other patients who are getting disturbed. So you can please go out and, speak to our manager or speak to the concerned person. So, and in that situation, you'll have to take control of the escalating situation and set limits. You have to be firm, but not aggressive. Because the moment you will become aggressive, again, there will be retaliation, there will be anger coming in, that will become difficult for you to manage. And then, of course, focus on what you can do and what they should do. So that's where you need to assert and tell them, see, I'm ready to help you, but this is not the way that you can get what you want. So you really need to calm down, listen to me, tell me what exactly you are looking for, and then, so assertion will really play a big role when you are interacting with them. One thing that you have to always remember when you're handling an aggressive patient party, keep your distance. So respect the personal space of the patient and your own safety. So around 3 feet distance is absolutely, it's a good idea, because it's safe for the patient and for you, because the other person also might feel, anxious when you go closer to them. So preferably have a table in between you and the patient party. It creates safety for both the parties. And also in the counseling room, having a 2-door policy. One, see, usually How many of you have two-door policy in your hospital, if I may ask you? Anybody who has two-door policy in the hospital, in the counseling room? Okay, Dr. Ravi says yes. So what is the reason, Dr. Ravi? Why did you have these two doors in your room? Was it with some intention or just by the way you created two rooms? You can unmute and speak, please.
No, ma'am, it just happened to be there. But I found it works to my advantage a lot,
So how does that
later.
how does that help you?
See, uh, it's a very negative thing actually, but we explain and we are talking to them a lot, and then sometimes they still need time to grasp for this thing. Then I just either I leave or they leave, and we can go there and then come back to them. So that's the main thing. We give
This is
them
what
time.
exactly I'm trying to recommend. This is what exactly I'm trying to recommend. See, if you have, usually if you are sitting in your room, patient party will be closer to the door. And if you want to go out, you will have to cross them. And if they actually become very aggressive and they become physically, aggressive, there is no way that you can protect yourself. So it's always a good idea. The counseling room should have two doors, especially keeping the kind of violence that is happening across the country. It's a good idea to have two doors, one for the patient party, so that in case if they want to leave, they can leave. Second, for you, in case if you feel uncomfortable, if you feel unsafe, if you want to give them time to think, you can comfortably move out of the room. And also you can get help from your people. So that's why I said it's a good idea to have a two-door policy. And Dr. Kapoor has written the answer: to escape violence. I think I completely agree with you. I mean, yes, this is the need of the hour, and we know that this is how we have to, protect our, healthcare professionals. Yeah. So having a two-door policy is not a wrong idea if you can have two. Also, when you are, of course, this is not normally how we do, but a lot of time we ask our security staff to handle or our gatekeepers to handle, and they go very, very close to the patient's family member. So this is more like, kind of, if this kind of body position you are getting into, either you or any of your team member, that itself can aggravate the situation. So that's not a good idea. Standing eye to eye or toe to toe is not a good idea, and it sends a challenging message. It also escalates anxiety in the other person, that I may be attacked. So maybe out of that fear that I may be attacked, they may attack on the patient, on the whoever the healthcare professional is in front of them. So when they are talking, avoid answering every statement, because they may say something that may not make much of sense. It's just that they're venting their anger. And please avoid speaking for the sake of speaking. It's a good idea to let them say what they want to say. A lot of time they may throw challenging questions at you. Again, those questions may be baseless, that may be just to trigger anger or a reaction in you. It's always good to take their attention to the issue rather than trying to answer their questions or reply to their challenges. Also, if you get into that argument, it usually ends up into power struggle and lose-lose kind of a situation. So it's a good idea to not answer to everything they're saying, rather answer only to what is important. Giving them an opportunity to vent is another good idea to help them calm down. So allow the individual to release as much energy as possible by venting verbally. But of course, whenever it is possible and it is appropriate, not that they just shout and call people and gather in front of your clinic or in front of your chamber. That's not the idea. But within the room, if they want to speak something, if you allow them to speak, that will give them a chance to vent their feelings. And if you can't allow that, then you will have to stay directive by saying, for example, if it is ICU, OT, labor room, or emergency, so maybe you'll have to say, I understand that you are dissatisfied, or you are angry, or you want to, address this issue, but this is not the right place to do it, you will have to please go out and do this. So the idea is you are trying to kind of, you're not allowing them to do whatever they want, but you are allowing them to win. Then when they are behaving, now see, you can see the aggression is going up, it's escalating. So that's the time you really need to set and enforce reasonable limits. So you'll have to offer choices and consequences, because for example, if they are becoming very aggressive, disruptive, you'll have to state limit and set directions clearly and concisely, that what is permitted and what is not permitted. When setting limits, offer choices and consequences to the acting out individuals. So for example, see, if you will not stop acting aggressive, I will have to call a security, or I can ask my managers to speak to you, and you can go and speak to them in the room. So what you are trying to do, you are trying to not only diffuse the situation, but also you are setting a limit, what is permitted and what is not permitted. So sometimes we actually, out of anger, we give some consequences which we cannot deliver. For example, I will not let you go, or I'll call police and I'll get you threat. So that's not a good idea. I think we really need to be careful not to promise such consequences which we cannot deliver. A very important thing here is to keep your non-verbals non-threatening. That's very important. Usually when they act aggressive, we are also angry and aggressive and upset. So that comes on our face, especially when the person is not able to listen. The individual is actually listening to your non-verbals. They are paying more attention to your non-verbals. So in case if your non-verbals are aggressive or even anxious, so they are getting cues from that. So it's important to keep your non-verbals non-threatening and keep them neutral. And your gestures, your facial expressions, movement, tone of voice, everything is communicating. So it's good to keep them as neutral as possible. In such situations, some expressions can aggravate the situation. For example, when you give an expression that I don't care, or I can't do anything, or what can I do? That's not my job. These are all good expressions. They are going to aggravate this situation. Rather than this, it's always a good idea to take a prompt action, reassure them of the prompt service, whatever you can do, make all efforts to reduce their suffering and minimize the damage. And at the same time, do not lose sight of the patient's welfare. So even if the patient party is acting aggressive, but you think that the patient needs oxygen or patient needs to be, provided first aid, so take their attention to the fact that we need to first settle the patient, and this can be, put on hold. So you are taking your attention and the patient's family's attention to the patient's welfare. One person who can control your behavior is you. So please avoid overreacting. A lot of time we also overreact to the situation, maybe out of fear, maybe out of anxiety, maybe out of anger, but we really have to practice to remain calm and rational and professional in such situation. I know it's easy said than done, but that comes with a lot of effort. But if you are able to bring this in, you will be able to better manage this situation, because your behavior is directly going to affect the behavior of the other person. So if you can demonstrate calm behavior, rational behavior, that can help the other person also get control. Of course, assertion will help you greatly to deal with that situation. In such situation, please avoid behaviors like shouting back, banging the door, throwing patient's file, or calling security without any provocation, because that can again aggravate the situation. So now you can see that things are going slowly escalating. At the same time, I think internally we are also going to experience overwhelming emotion. So at that moment, it's very important to be mindful of how you are feeling. If you're scared, if you're upset, if you're anxious, you should know what you're feeling. You should be able to identify your feeling. Do not ignore your feeling, because sometimes out of anger, aggression, we also overreact to this situation. So know your hot buttons, and in case if you're not able to manage, ask someone else to come your place and handle it. Because if you are not able to handle, either the patient will act out, or might be you would overreact to this situation. Crisis stage 4 is acting out. That means the situation has not been, you or your team have not been able to contain the anger, and the person has actually become aggressive. and is becoming violent. So the person has actually lost control of his or her behavior and can act out. So he or she may start throwing things, damaging furniture, hitting people, and they are usually not capable of reasoning at that point. So in such a situation, the best thing will be, how are you going to make sure that you and your team are safe, people around you and you are safe. So it's all right to activate your emergency procedure as directed by your system. It could be a push button that you have, red button, or what do we use that? A code? Violet? Code
Code
violet?
violet. Code violet.
Code violet, yeah. Code violet.
Violet for violence. It's like
Violence, yeah. Code violet. So that has to be activated. Actually, if we know right from the beginning that this thing can go out of control, we can keep them ready on standby, but only have them in when the patient party actually becomes aggressive. Because sometimes they are just talking or being aggressive, but we bring in people and that itself can aggravate the situation. So very sensibly we have to choose when do you want the emergency team to intervene. But yes, when you know that they have become aggressive and they are throwing things or hitting people, it's a good idea to have people to help you and save you and protect your team. Now, once everything is done, they have hit you and they have damaged things, they have misbehaved. Usually, you will see the stage 4 is tension reduction. So that is where their emotions will calm down. The person gains rationality, realizes that, okay, I misbehaved, I shouldn't have done this. So it's something like when their emotional mind has hijacked their rational mind and they are just out of anger, rage, they have gone out of control. But after that, once their sensibility comes in, they realize that they have regretted and they may want to apologize or compromise. So has anyone ever experienced something like this where the patient party did something and then they came back apologizing? Has anybody ever seen something like this?
3 days back, I have experience.
Okay. So what exactly happened? Like, how did you handle that apology or their willingness to resolve?
Like, in the morning, I am just going to my floor. In 9th floor, we have an ultrasound room. The patient party came and he became rude. The reason is maybe his wife said over phone that someone misbehaved with his wife. His wife came for ultrasound, pregnancy or something else. I know the consultant. The consultant is Dr. Dida sir, is a renowned professor. So patient is in the bed that she is not prepared. So that's why maybe consultant said, please go back, get prepared, then come. Then the patient misinterpret this to her husband that doctor misbehaved with him. So this guy using the references, some of the senior managers of our company, and I said, this is not actually like this. This is actually this. Your patient, your wife is pregnant as well as she cannot control the urination problem or something else. This is not actually problem. The problem is this. Maybe this is the complete misunderstanding from your side, but from our side, everything is okay. I think, and I have gone to there and I talked to our floor in church and I said, please control this. Go to the doctor's room and advise where needed, and I think it will be okay. Then patient party says, okay, sorry, bro. That's it.
So you managed it?
Yes, he managed.
Okay, thank you. So Shivraj, you want to talk about something? Patient?
Yeah, I mean, it was not the relative, it was the patient himself, like who created violence in the room. Where it was. This happened just 1 month ago. Maybe it was because of his condition and he was quite deteriorating. He was not happy with his health condition. He damaged everything which was in that room. Literally, we had to lock it and then call the security. And security also didn't manage him. And ultimately, we left him alone whole night. And morning, we have something like PALS here, like patient advisory and liaison services, where they can complain if the patient is not happy with the care. And second thing is like chaplaincy, like as good as counseling itself. So both of these worked, and patient gave a, I think, 3 to 4 page apology letter. Like he expressed everything what happened to him and what went wrong with him. And then that was taken as an example, and we made a short documentary on that, so that which can be displayed for patient information.
So hospital psychosis is a very common situation we see. But how many of our staff members can actually identify and know how exactly are they supposed to handle this? I personally have experienced, I had a bad experience of hospital psychosis. My father got operated, he underwent bypass surgery. Everything fine. It was day 3, I think, in the ICU. I had gone out of Delhi for a day. And on my return, I got a call from the hospital that your father has become very aggressive, very, violent, and he's abusing the staff and he's misbehaving, and we have put him in the room. And the moment I, reached, I could see, and they started the treatment. Not that they did start, they started treatment for psychosis, but their handling was not sensitive. It was not, with knowledge that this is a normal, reaction of the patient when they are in the ICU for a little long, or they have undergone any serious condition. But the way they were reacting was as though it's the patient who's creating the problem. I think that awareness has to be, kept in mind in the hospital staff, that you don't have to react to it. Of course, you have to manage it, but you don't have to react to that situation. A lot of time we don't know how to handle it. But yes, usually I think the family would, the patient or the patient party would realize that we have misbehaved and we need to, apologize. And sometimes they would apologize, sometimes, especially if they have to continue the treatment, or if they are still under our treatment, so they'll come and apologize. I think the person who has handled this situation, for him or her, it is very difficult to let go. But I think we have to learn that we have to, open an opportunity to the positive change, because there's no point dragging it beyond that point. It's all right to understand that the patient and the family is under a lot of stress. Of course, physical violence cannot be permitted or can be okayed. But if it has been, something that they became aggressive or they started arguing, that you will have to really have that courage to let go of that experience. So it's a golden opportunity to reconnect and solve the problem and move on. So communicate with the person as they calm down and resolve the issue. In case if you need to take some action, some disciplinary action, some legal action, if you think that that's a need, you will. I'm sure you and your organization will definitely take it. So I think once the situation has been managed, it's important to document. Many of you may be having already an incident reporting format in your hospital, but otherwise, I think it's very important to write some details about the incident, so that tomorrow, in case if there is something, you have some documented evidence of what exactly happened. So name of the aggressive patient party and the hospital staff who attended this situation, little bit about the background, what exactly happened, how you responded, what steps you took to mitigate this situation, what was the outcome, what did both parties ultimately agree to, what aggravated the situation, because you so that in future you can prevent those issues. Any suggestions regarding the solution or situation, and kappa, I think that's very important, so that we remember, we can reduce the number of such kind of situations. And how can you be reached for questions or any query, that has to be part of the documentation. Of course, reflection after the situation is helpful in learning from what has happened. Sit back and check how you're feeling, how you felt, how you managed. Discuss with your colleagues. You'll get a lot of new ideas from your colleagues. Like, for example, we have discussed here a couple of things, and you have given wonderful inputs in telling how you are managing your situation. Read material to update. A lot of material is available on Google. It's important to learn how to handle this situation. So don't hesitate taking programs on learning how to do crisis management or preventing violence and aggressive reaction. So this was in brief about handling aggressive patient party. Of course, we'll be doing role plays in the last two sessions, and we'll try to take one of these. We could have taken this situation, Zahir, the one which you have handled, where the patient felt that somebody has misbehaved with me, and how you handled. We could have taken this. Maybe in the future, this thing we can take one of the sessions. We can take this. So, any questions about what we have discussed? Anything you wish to say? What is kappa? So kappa is corrective action and preventive action. So if any situation happens, we analyze this situation in a very objective manner, and from that experience we learn what is the immediate corrective action we can do to resolve the situation, and what can we do to prevent this from repeating. So that is preventive action. It's a wonderful tool to keep improving your services and work environment. So if there are no more questions, we have two presentations today. Dr. Janvi, are you ready? And Shivraj, are you ready? So I would request you to make sure that your presentation is over in 10 minutes time, because we only have around 10 minutes, so we may be going beyond 10. So we will go up to 10:10. So Shivraj, if you're ready, I think I will request you to make the presentation. Oh, sorry, I need to give you the permission to share screen. Give me 1 second. Yes, you can share the screen.
Okay, ma'am. Thank you.
Thank you.
I hope the screen is visible.
Yes.
So before I start in the discussion today, we have is on reflective questioning, and almost I can say like most of this part was covered in the previous presentation and the scenarios what we did today. So before I start the actual discussion, I would like to focus on both of these pictures, and I would request all of you to give comments on these two pictures. Like, what do you think, or what do you understand by looking at both of these pictures? Yeah, Dr. Ravi Matani says annoyed versus happy patient. Like, what do you understand? Like, what's happening between those? I mean, patient or the doctor, or patient or any relatives. Irritable patient. Okay, let's go to the next one. So again, there are two pictures, and there's something happening between the doctor and the patient here. And there is something running in the mind of the patient. So how do you reflect on this? Can chat in the comment. Okay. Dr. Farah says mindful and unmindful. Okay. Okay. Dr. Vaibhavi says what is running in the patient's mind. Okay, right. So let's move on to the actual discussion after all these pictures. So the reason behind this was like asking what's happening is to just reflect what's happening. So the question, reflection or reflecting question is like focusing on the patient's own experiences. So usually this is most often used in the educational settings where the students are made to understand and put questions on their own self to understand, okay, what we learned and how was it, and what most of it has to be taken from that point of view. So it is nothing but metacognition, which plays a very important role in the process of thinking and learning. So most of the things we learn, but we don't think. So, for example, I say there's some teaching or interaction going on between a patient or the doctor, and at the end of the thing, the patient accepts what the doctor is saying rather than thinking on what information the doctor has given to him. So most of the time it ends up one way, or they may have some questions related to the care as what conversation we saw today. So it starts with 6 strategic questions, and we come across this in our day-to-day life. They are like what, when, who, where, why, and how. If we put these questions on ourselves when in each situation, we tend to understand most of the things out of that, and we may get answers for what our reflections mean here. So there are 2 types in this reflection. One is on action and in action. So on action is after the event. When the event takes place, we tend to ask ourselves, okay, what happened? And then we look back and see whether it was good, whether it was bad, whether it was useful, whether it was something which I did good, whether it was beneficial to the patient, etc. Same way, it is in action, that is, which happens during the event. We can say it is like a formative process which forms and which builds when the interaction or when the situation goes, and we act accordingly on that case. So again, the same. The process is which starts with what happened, or what are the facts. So what? Next thing comes is so what. So what happened after that? So what does that mean to me? How did I interpret it? And what did I learn out of it? So after that, at the end point, I will do like, now what? What should I do? What better things have been done? So, and then we set a plan, and that is what is our learning experience means, which ends up into reflection. So there are some advantages, like we develop a habit of questioning, whether it is to self or to the person whom we are talking to. And then it helps us to identify things, and which makes us help improve the care or concern about that. Then challenges which come across, like we saw the communication skills and communication patterns now, and apply what we learned, apply those things in our day-to-day activities. Then problem solving skills, like the previous, just now we finished a presentation and we saw that how those 4 stages go across and how we solve them. And everything should have evidence, like what we do is having evidence because we learned it and we have applied it. But there are some disadvantages also, like it's time consuming, we can't use it in all situations. We need to have a proper reasoning for what we are doing. And it helps us to evaluate our own practice, which most of us, we don't feel happy evaluating our own self. And these may create confusions when we have experiences or situations which are mixed, and we mix our emotions and feelings with that, and we don't come out with something which is useful for the patient. So next are some of the do's and don'ts when we have to do this. So when we tend to have questioning, they should be like, we have something curious out of it, and we have some assumptions coming out of it. It should be creative, and we should engage in those kind of questioning. Otherwise, it will just end up again like a question and an answer. So it should trigger, like I said in the beginning, what, so what, and what next. So it should trigger what's the process is. And some of the don'ts, as usual, like when we see patients asking so many questions, what we do? We tend to become bored, or we get angry, we get distracted, we get suspicious about the patient or the relatives' behavior, whether they trust us. Oh, they are doing it purposely. And at the end, what happens? No outcome. So there are, I have 4 questions here for all of the participants. I would just like to reflect I want you to reflect on this. Which patients tend to draw attention? And second was like, are there patients you find it difficult to get along with or to reach, or how do you feel about this? You can answer it at the end of the discussion, like how we can go ahead. Then what information or knowledge are you assuming patients have when they meet you? Where would they have acquired this knowledge or information? How have you responded when they do not appear to have this knowledge or information? And the last one is like, what's presenting a challenge to you recently when it comes to patient education that you did not think would present a challenge? We can take any one of these and we can discuss. So at the end, I would like to say reflection does not necessarily happen, but conditions can be structured to encourage it to happen. This is nothing but to make the learning and more impactful and give the patient a positive experience of what they're reflecting in the day-to-day situation. And that is again a learning experience for us. Thank you.
Thank you so much, Shivraj. I think the whole idea of this as a pedagogy is when you are dealing with adult audience. As I said, I mean, I've been saying it repeatedly, you can't teach anything to anybody. But if you ask some intelligent questions, you can make them reflect. And the same strategy can be used even with patients. For example, patients who are not ready to work on their lifestyle, patients who are not complying with your treatment. If you ask them reflective questions, what do you think will be the outcome if you don't control your sugar? What is your understanding of you are not complying to the treatment protocol in terms of your blood pressure control? So when you ask these reflective questions, I think the answers come from within. But it was really very well presented, Shivraj. Thank you so much, and dot on time, I would say. Thank you. That's so good. Yeah. Any questions you wish to ask to Shivraj, please? But this should be used as a pedagogy in your trainings. It's very helpful pedagogy. It's very helpful pedagogy. Especially with adults, you can't directly give them answers. Even at home with my kids, I don't give them the solution. I ask them questions and I ask them to reflect on it. So the answer will be automatically what you were expecting. So that's another way you can use at home also. Third eye reflection. Thank you, Zahid. Thank you. So if we have no more questions, I think I would request Dr. Janvi to go ahead with her presentation. You can share your screen. I've given you the...
So good evening, everyone.
Good evening.
So I hope you can see my screen.
Yes, we can see.
Yeah. So we all know Simon Says. So we will be doing a small activity. I would just request all of you to please switch on your screens. And I would request Dr. Indu, please, if you can be the judge for this activity, because I'll be caught up for this thing, but you can at least have a look. So what we are going to do is let us wake up and shake up. I know this 10 o'clock in the night and we're almost end of the session. But, we are just going to, I'm going to say Simon Says, and all of you are just going to do opposite, because we don't like Simon and we are not going to agree to what Simon says. So I'm going to read out the activity and all of you, please do the opposite of what Simon is saying. So let us begin quickly. Simon says, sit down.
Dr. Janvi, you can stop sharing the screen for a few seconds.
Okay.
You're doing this activity because I can't see everybody.
Oh, sorry. So how do I?
Yeah.
Okay. Yeah. So Simon says, sit down. Simon says, raise your right hand. Simon says, open your mouth. Simon says, smile. Simon says, shake your head side to side. Simon says, pull your right ear. Simon says, be awake.
Baby is still standing. Because you didn't ask her to stand. So responsible.
Yes. So Simon says, be awake. Simon says, lower your eyebrows. Simon says, put your chin down. Simon says, smell something good. Simon says, mute yourself and be quiet.
So everybody can unmute.
Hello.
Hello, it's going to sleep.
Excellent.
So this was a small activity to just begin my talk for tonight, which is ice-breaking activities as a way of teaching and learning. So I'm Dr. Janvi Shah, and I'm the medical superintendent at Bhatia Hospital. And just want to quickly say what are ice-breaking games. So ice-breaking games are basically fun activities. Usually they are conducted to just to get to know each other. It is conducted usually in the beginning of the session or the first session. Usually, of course, you can have it over time period. These are nothing but just activities which can be either are designed to get to know to each other or to get to get to know more about the topic. Usually it is helpful when it is a mixed group, like currently our group. Over the time we of course get to know each other, but if it's the first session, like exactly Dr. Indu did, we had an introductory section. So there can be various ways in which you would want your group to know each other. And especially ice breaking activities are also designed to warm up online learning sessions, because we are remote, we are not in person. So it usually helps to get attention also when people are just wandering about and not listening to you. So ice breaking activities may just involve just like playing a small game with each other, or just responding to certain funny or get to know comments. It can involve why they are taking the course, so you can connect it by sharing something meaningful related to course. You can ask every student to just share an article or to share an experience. How do we do in our lectures currently? We relate to our topics, so that also can be a part of your ice breaking activity. Or it can be creating videos, going about. It can be related to the topic, it need not be related to the topic, but there can be various ways in which you can do your icebreakers. So why use icebreakers? Basically, because especially if it's a first time lecture, you don't know your students don't know you, or they don't know each other. So it is just to create a very relaxed environment. You're just encouraging your students or your audience to share ownership. It helps them to be a part of the session with certain ice breaking activities, so they get ownership of the session. It becomes an excellent way in building rapport. So if you have your courses in the future have some group activities or something, so icebreakers are a very good mechanism in which you can form team. And of course there is a collaborative group work and a very good informative session at the end. And it is always it is a very sometimes, like I said, sometimes you can have certain serious or monotonous topics as well. So our ice breaking activities can be a good interruption to those monotonous or serious talks. It just lightens up the mood, and people really enjoy the session. So certain considerations for using ice breaking activity, what you want to achieve with an icebreaker. So like I said, do you want it as the first time in your session, or to break a monotonous? So what you want to achieve, you can place your ice breaking activity or the type of activity depending upon it. Thinking of your population, so who are your audience, whether it's an online or whether, because this was an online activity, I did this, Simon says, if it's a physical activity, if it's a physical presentation, you can actually have some physical activity or small games, team building games within the groups. So whenever you're planning an ice breaking activity as a part of your session, you please ensure that you have the entire, if there is supplies, will the space around you is okay. All these of course are not issues when it's an online session, but if it's a physical session, you may have to have these things ready. Would the activity lead to any issues of confidentiality? Because certain ice breaking activities can have, when you have to talk about yourself, or reveal something about a person. So in case if you're planning that, please keep in mind these points. Does the activity accommodate varying abilities? So sometimes it might be something to draw or something to express. Whether all the category of students you have in your talk, whether they can actually be able to do all this. So it's very important to think. These are few things which we may think while, which type of ice breaking activity you want. So certain do's and don'ts with ice breaking activity. Of course, introduce the activity to the group. You'll have to explain to them. Explain why you're doing it. So what is the reason you want to go about it? Establish a symbol when the activity is over. It is, if it is like a group activity or something, so like a bell, or when I say something, it might start, it might begin. This is so that you just give your instructions clear cut to the students, and so that they can enjoy the activity as well. Help the student find a partner. Sometimes it may happen that you may have a activity which can be a group activity. So of course it can happen that suddenly those who are friends, they may just club together while isolating some person. So if you are the conductor, so try to ensure that everyone has a group or everyone has a partner when, if it's a activity which involves partners. Indicate who will start first. It is just that, if it is something which is in a serial manner, so someone whose birth date is first, or someone whose star sign comes first. So just a way randomization in how to go about the activity. And of course, at the end of the activity, if it's related to your topic or something which has a connection, you can always debrief on how you have done with the activity. Certain don'ts. Don't assume that everyone will be able to manage it. So if you may happen that you may need to take a break and actually help out someone. Do not isolate anyone in particular. So like I said, there can be certain ice breaking activities which can lead to questions. So please do not pinpoint or isolate to one particular thing. Safest is to have a group activity that will help even in team building. Having activities which can encroach something about personal space may not go well with everyone, and people may not be comfortable. So be as general as possible with your ice breaking activity. Do not have any scoring mechanism because it's just that no one it's just a fun thing, or we are doing it to have a relaxed environment. So we don't want any scoring mechanism like a high score and a low score, and again isolating someone with a low score. So that's it for my talk. Ivan says thank you.
Thank you. Very interesting.
So any questions?
So I think we really need to bring more fun to the programs and sessions, and therefore we should have more of ice breaking acting, not only in the beginning but in between also, like Janvi has mentioned, to break monotony. I'll share a small folder. I think it has around 50 ice breaking activities. I'll share in the group, and you can use those activities for your programs or your sessions, what you do. But very nice, very interesting activity, Janvi.
Thank you, ma'am.
And again, you finished on time. Congratulations. I think both.
Thank you.
So I'm glad that we are learning to even stick to the timeline. That's very, very important. Very important learning. So if there are no more questions, should we close it here? Because I know we are already 10 past 10. And in Bangladesh, it's already 10:40. It's very, very late. Thank you so much, everyone. See you in the next class. I'm sharing the feedback form in the WhatsApp group. Give your feedback. Not for the pedagogies, but for the session. I don't want pedagogies to be evaluated, but the session, of course, I would want. Zahir, is that your son or daughter? Couldn't hear you. Your audio is muted.
Madam, my daughter.
Oh.
Hi, Surya.
Hello.
Papa, hi.
Bye-bye. Good night.
Good night. Thank you. Good night.
Thank you, everyone. Thank you.